Hi everyone, my name is Sharif Ismail. I'm a PhD student from the London School of Hygiene and Tropical Medicine. I'm going to spend the next few minutes uh, presenting this work in progress, which is based on research that's part of my PhD thesis, for which the focus is on vaccination delivery systems and their responses to shocks, and in this case, large-scale population movement, with a particular focus on refugees. So this work is supported by a range of collaborators too, who are named on the first slide here. So the shock of interest here is really in thinking about what happens to vaccination delivery systems on a national level when you have large-scale movements of refugees in the context of a humanitarian crisis. And the particular focus is Lebanon here, which has experienced a number of movements in recent years linked to the crisis in Syria. And the question is thinking through basically what happens to vaccination delivery in this sort of setting. So what is the nature of the system response to that kind of population movement? What characteristics explain system adaptation, if any, arises? And thinking slightly longer term, what sort of strategies could be implemented to reinforce capacity to maintain or exceed population vaccination coverage rates? And the premise here is that vaccination matters on a population level because you need to ensure a reasonable level of coverage in order to maintain herd immunity. Otherwise, on a population level, vaccination delivery simply isn't effective. So it really matters to try to think about how you can improve people's access to and delivery of vaccination to different populations. The problem is that we don't really have a clear sense at this stage of what sort of factors affect a system's ability to adapt to a shock like this, and of the areas of the system in which you might act in order to try and reinforce capacity to respond in the future. So the focus for this work in outcome terms are on coverage of two key vaccinations, or vaccinations for two key diseases. So on the one hand, diphtheria, tetanus, and pertussis, a combined vaccination focusing on the third dose of that vaccination. That's because this is an internationally accepted benchmark performance measure for vaccination systems on a national level. The WHO tends to report on this as a baseline measure of how vaccination systems are doing in countries around the world. Also looking at coverage of measles through MCV1 and MCV2 vaccination, and that's because although measles is part of the routine vaccination schedule in many countries, this is also a very good indicator of systems' capacity to react quickly, because it's usually a priority to vaccinate people for measles in the event of refugee movement, because it's a highly transmissible infection, and if you don't act quickly, you can get outbreaks fairly quickly. In design, this is a multi-step process, this project, which involves obviously preliminary scoping work, which is now largely complete, then processes of stakeholder engagement through key informant interviews leading up to the production of a causal loop diagram, and hopefully implementation as a quantitative model through which it will be possible, I hope, to test the effectiveness of different system strengthening interventions. Now, one of the features of this project is, unfortunately, it's proven quite vulnerable to the impact of COVID internationally. And so field work is now actually on hold for this moment while we wait for things to sort of ease up in terms of access to stakeholders. But it is possible, even at this fairly early stage, to give a couple of sort of headline observations or points from the work that's taken place so far. So one of the first and perhaps most important observations is that there are real analytical challenges when you're thinking about the effect of a shock on a system in disaggregating effects that arise from that shock relative to longer term stresses that the health system is subject to. And that's particularly the case in humanitarian crises, where there are quite extensive system vulnerabilities. This is no less the case in Lebanon, where the health system has been vulnerable over a number of years as a result of shortages in funding, but also lack of human resource and so forth. There is a second really quite interesting question around how you factor in potentially transformative change in service delivery models into a system structure that's basically intended to maintain relatively stable over time. And one of the features of this project is to try to answer the question of whether or not actually what's happened in response to this shock has been so transformative in system terms that a wholly new system has emerged in a variety of different characteristics since the onset of the crisis. I'll stop there. Thank you for your time.